So should I start?
Yeah, you can start.
Yeah, please go ahead. Go ahead. We're already late. No?
Yeah. Okay. Today I'll be talking about the remaining posterior circulation system, that is basilar artery and the PCA. Like we had seen the embryology last time. So to sum up, the vertebral artery which was formed from the cervical intersegmental arteries, it fuses and causes an anastomosis which forms a proximal basilar artery, and the remaining longitudinal anastomosis that happens between the persistent trigeminal and hypoglossal artery forms a distal basilar artery. So the distal basilar artery is formed by this anastomosis, but the proximal one, the vertebral artery, has to be completely formed and anastomosed to form this. So the fenestrations that are most commonly seen are in the proximal basilar because of the non-fusion of these vertebral arteries. Coming to the basilar artery, so it originates at the pontomedullary junction, travels anterior to the pons and terminates near the pontomesencephalic junction, and averages 32 mm in length. So 45% of the times the course is straight. It is curved in 35% and it is tortuous in 20%. The outer diameter is typically constant, except for a widening at the basilar bifurcation, which looks like a cobra-like appearance in 16% of the cases. The basilar artery, the important branches are the anterior inferior cerebellar artery, which is the first proximal branch, and superior cerebellar artery is the distal most branch, and the others are the transverse pontine arteries, or the pontine arteries, the one we call. It is embryologically said that all the arteries were the transverse pontine or the perforating arteries, and these two become significant to supply as the development of the brain occurs and the cerebellum develops. It requires a larger supply. So these two, the AICA and the SCARP, become more prominent to supply those structures. So this is the AP and lateral view of the basilar artery. As we can see here, this is the basilar artery and formed from the vertebral artery. Here we can see the first branch, that is the AICA. Then there are some transverse branches which are not very seen very clearly in angiogram. And then this is the superior cerebellar artery. And then it bifurcates to PCA. Here we can see in the lateral view as well. This is the pica that we had seen last time. This is the basilar artery, which there is a anterior inferior cerebellar artery. Then there is a scar just before the PCA bifurcation. So this is also an AP view of the basilar artery, where we can see superior cerebellar artery just below the PCA bifurcation, and we can see an AICA here on the left side. However, on the right side there is AICA and there is a common trunk which forms an AICA-PICA trunk. We'll come to this later. So the AICA and PICA, they have a mutual, there is a constant supply. That is, if AICA is smaller, the PICA will take up over the AICA, and it will supply also the branches of the AICA, the regions of the AICA. So this is how in this we can see that there is a common trunk coming from the right side, and then it is getting divided into an AICA branch. We can see here above. And then there is a pica which supplies the posterior inferior cerebellar region. And on the left side, we can see that the pica is a hypoplastic one. And so the AICA will supply its own region, as well as it will have some supply to the region where the pica used to supply. And in the lateral view, we can see these two AICA, which are like a M-shaped configuration. This is how we identify them in the lateral view. So coming to AICA, it is 9.6 mm distal to the vertebrobasilar junction, and this is it travels posterior, inferior, and lateral, across the pons and goes towards the cerebellopontine angle, and then terminates by passing over and sending branches to the anterolateral surface of the cerebellar hemisphere. It is the smallest of the three cerebellar arteries, and it has, as we discussed, it has a reciprocal relationship and extensive anastomosis with both SCA as well as pica. And coming to the segments of AICA, so there are three segments. One is a premeatal segment, which starts from the origin of the vessel to the 7th and 8th cranial nerves. Then there is a meatal segment where we can see this loop where it goes through the internal auditory canal. And then there is a postmeatal segment where from the CP angle, it divides into a rostral trunk and a caudal trunk. So the rostral trunk goes medially over the flocculus to reach the MCP, and then it supplies also the superior part of the anterolateral surface of cerebellar hemisphere, and caudal trunk goes inferiorly and supplies the inferior part of the anterolateral surface. So here we can see these two and AICA.
Hello.
This is the premeatal segment. Then this is the loop that forms the meatal segment, and then there is a postmeatal segment. And then we can here also see some of the transverse pontine arteries as well. And the similar loop and the premeatal, meatal, and postmeatal form the M-shaped configuration. So the branches that come from AICA are predominantly from the premeatal and premeatal region. And the perforators, the brainstem receives small perforating branches from these premeatal segment, and also some recurrent perforating branches from the meatal segment. Also, internal auditory artery can arise from AICA in 45% of the cases. It can be premeatal or meatal, and it travels along with the 7th and 8th nerve to form the loop into the internal auditory meatus. And then there is subarcuate arteries and the cerebellar cortical branches. So there are variants in there are very less variants reported in AICA. Some of them are the duplication and triplication. However, origin of the artery is single in most of the cases, and sometimes anomalous origin can be seen from the AICA. So this is a schematic picture which is showing this is the SCA and this is the AICA, and then there are these perforating branches, paramedian arteries that are seen here. Here it is shown that sometimes the two perforators become dominant as compared to one, and they form two AICAs. So here we can see two AICAs origin from both sides. However, here important thing is when there are two AICAs present, the AICA which has the position of the actual original AICA will supply the most of the region of the AICA, and the lower AICA will supply will go down inferiorly and medially, and also supply some part of the pica. And it is important to see that the number of perforators or the pontine arteries between the SCA and AICA is very important. So whenever there is a difference in the origin of the AICA on both sides, the number of perforators accordingly change to supply the remaining ventral pontine region. So here we can see the origin is not at the same level. So the origin on the right side is lower as compared to the origin on the left. And accordingly, the pontine arteries are seen more here as compared to the other side. Sometimes as the vertebral artery does not bifurcate at its position of pontomedullary junction, and it causes a foreshortened basilar artery, and it fuses at a little higher level. So because of this, the AICA actually origins from its original position only, but because it is not fused, the basilar artery is not fused at its original position, the AICA arises from the distalmost portion of the vertebral artery. So here we can see it is before the fusion, the AICA originates. Then, as we discussed before, there is a reciprocal relation between the AICA and PICA. So whenever there is AICA or PICA, one of it is hypoplastic, the other will become dominant, and it will supply both the regions. So here we can see the AICA on the left side is hypoplastic, and so the PCA is very much dominant on that side, and it supplies both the regions. And we can see here as well, the PICA is hypoplastic, and so the AICA is taking over the region of the PICA. This is also, it shows that AICA and PICA has a connection, but also superior cerebellar artery comes into picture when both are hypoplastic. Like in this picture, the left side is taken over, the PICA has taken over the left side, but on the right side, AICA and PICA both are hypoplastic, and so the superior cerebellar artery through its hemispheric and collaterals gives supply to the regions supplied by AICA. So coming to the second branch, the other branches, that is the basilar artery perforators. Most of the perforators arise from basilar artery from its origin up to the ska. And there are few perforators which arise distal to the ska. There are no perforators which arise directly from the tip of the basilar artery. So there are these perforators have paramedian or medial perforators which directly go into the brain, and the others which are circumflex, which travel a certain distance, go posteriorly, and then pierce and go into the brainstem. So they supply the ventral region and the paramedian region, and also so these are the median and paramedian branches, the short circumflex branches and the long circumflex branches. Here we can see those transverse pontine arteries, and some of these arteries become more dominant as compared to others, which are also called as transverse pontine arteries, and if they their supply may cause a larger infarct as compared to a smaller perforator supply, and may also cause a ventral pontine infarction and locked-in syndrome. So this is the basilar perforator supply. As we can see, some perforators have reached only till this region, and the median perforators have reached up to the facial colliculus region. So according to this, the depending on the perforator which is blocked, various syndromes can occur, which can involve the corticospinal tract, the MLF medial lemniscus PPRF, as well as the facial colliculus, the 6th and the 7th nerve. So also in between these perforators, there are some collaterals which exist, which are angiographically invisible. And depending on those collaterals, sometimes the clinical recovery is different in various patients after the brainstem infarcts. And as we saw, one of the perforator becomes a large one, which is called as transverse pontine artery. And if that gets occluded, a ventral pontine infarction can occur. Then coming to the superior cerebellar artery, this is the most constant cerebellar artery, and it always arises immediately prior to the basilar bifurcation. And this comes into contact with the 5th cranial nerve in 50% of the cases, and is a target for microvascular decompression in trigeminal neuralgia. So here we can see this superior cerebellar artery, which travels posterolaterally around the brainstem just before the bifurcation, and it is inferior to the 3rd and 4th cranial nerves, and this is the superior to the 5th cranial nerve. And then it after the cerebellomesencephalic segment, it gets divided into rostral and caudal trunk. So the rostral trunk gives the direct and circumflex perforators. Predominantly it gives the Wormian branches here, and they are just parallel and inferior to the PCA, and also the supplies the paramedian aspect of the cerebellar hemisphere, and the caudal trunk supplies the superolateral surface of the cerebellar hemisphere, and superior cerebellar peduncle and pendentate nucleus. So as we saw the segments in PICA and AICA, there are segments in SCA as well. There is anterior pontomesencephalic segment, a lateral pontomesencephalic segment, that is an ambient segment, and a cerebellomesencephalic segment. These are all the 3 segments which form a loop. So after the cerebellomesencephalic segment, that is a quadrigeminal segment, that is a groove between the cerebellum and midbrain, it gets divided and forms the cortical segments. That is the Vermian branches and the superior surface. So the branches of SCA are also the similarly, they also have perforators, which predominantly all these come after the, that is from the cortical segment, that is from the trunk. And there are some pre-cerebellar arteries which supply the deep nuclei, and other are the cortical branches like the Vermian branches as we saw, and the hemispheric branches. Sometimes internal auditory artery can also origin from SCA. So here we can see the SCA, and we can see there are these Vermian branches which are in parallel with the PCA. So these are the Vermian branches, and this is the AICA, and they all form a hemispheric branches, and they have this region where it is also called as a watershed region. As we can see in the late arterial phase, there are some watershed zone over here, and supply is up to here. So as we saw that sometimes the vertebral artery fuse a little later and form a foreshortened basilar artery. There can be also early bifurcation of basilar artery causing a short basilar artery, and in such during such scenario, the SCA can origin from the P1 segment. As we can see from here, the SCA is originating just after the bifurcation. So as we saw the duplication in other vessels, there can be a duplication in SCA as well, as we can see here. Sometimes it is present in 25% of the cases in unilateral. This is a case where there is an occlusion at the pica origin. So in such times, as we saw prior, the SCA takes over, and it can give a collateral supply, and its hemispheric branches can go up to the pica region. So there is this balance between the SCA, AICA, and pica, and they take over whenever the other artery is either occluded or is hypoplastic. So this is just to show the pictorially the supply of all these various arteries. Okay, then coming to the posterior cerebellar artery, these are the paired vessels arising from the basilar artery. As we have seen the embryology prior, that is the ICA has the dominant supply over the brain during the fetal development, and initially this caudal division of the AICA comes behind and forms the PCOM, and that is how the vertebrobasilar system is formed, and then slowly the PCOM regresses. So the initial part, the part where this PCOM fuses with the basilar is the stem of the PCA, and from this stem initially arises the choroidal branches and the other cortical branches, and then slowly when the PCOM regresses, this becomes the distal part. Like we can see here, this is the proximal PCA, and then after the PCOM there is this distal PCA which supplies the cortical and choroidal branches. So there are again 4 segments of the PCA. So the first segment is the P1 segment, which is from the bifurcation up to the PCOM junction with the PCOM. Then P2 segment is from the PCOM to the posterior aspect of the midbrain. So the whole thing, the longest one is the P2 segment. And then comes from the posterior aspect of the midbrain to the calcarine fissure is the P3 segment, which is a shorter segment. And then comes the P4 segment, which has the terminal branches distal to the anterior limit of the calcarine fissure. So here we can see pictorially all the branches. That is, this is the PCA, this is the PCOM, so this becomes the P1, and the P1 and P2 together, they also give branches to this the perforating branches, which come from P1 as well as P2, and these are the thalamogeniculate branches. And then after that, it also gives 2 choroidal branches, that is posteromedial and posterolateral choroidal branches. And then it gets divided into this posterior parieto-occipital cortical branches, that is parieto-occipital, and the calcarine branches. So as we saw the perforators, the PC also has similar perforators, which are direct perforators, which are called as posterior thalamoperforating branches, and then the circumflex arteries, which may be short or long. So all these perforators, they do not anastomose among themselves after entry. However, they are anastomose in the subarachnoid space before the entry into the brain. And sometimes in pathological stage, they may even anastomose within the parenchyma. So these are the anastomosis shown. So this is the DSA showing the PCA. Here we can see, we cannot see the P1 segment, but after but it shows some perforating branches which we can see here, and then comes the P2 segment that we can see here, and then these are the two PCAs, and then comes the P3, and then comes the cortical branches. So here we can see the PCA branches more clearly. These are the thalamo-geniculate branches. Then comes the P2. P2 is a little tortuous, and then it becomes straight when it becomes a P3. Here we can see this two posteromedial and posterolateral choroid branches, and the same branches here in the right side we can see in the late arterial phase there is a choroidal blush seen. Then we can see the other arteries like the anterior temporal and the posterior temporal arteries. So variations side to side asymmetry can be seen in 52% of the cases. And when a fetal PCOM artery remains persistent, the ipsilateral P1 typically becomes hypoplastic, making it appear absent or occluded. So here we can see the PCA on the right side has a good caliber, but on the left side it is having a less lower caliber. But here we can see that the PCOM is supplying the major, so PCOM has a larger caliber. Also here we can see in this DSA we can see that both the PCAs are not seen, like the right side PCA is not seen after the distal cut, there is a cutoff, and on the left side of the PCA is not seen clearly. But when we see the internal carotid artery injection, we can see that on the left side there is a fetal PCA, but on the right side there is no fetal PCA, so right side is the occluded one. So there are various anatomic variants that can be seen in the paramedian supply. That is the first, the P1 segment and the P2 segment which supply the perforators. There are various variants. So like sometimes both the P1 segment might supply the thalamo-geniculate arteries and thalamoperforators. Sometimes both sides supply might come from one side, but it bifurcates on both sides. And sometimes only one trunk comes through the one side, and then it gives supply to both the thalami. So this is what we call type 2B is called as the artery of Percheron, which unilaterally block can cause a bilateral infarct. So coming to the P2 segment is also called as the ambient segment. It is a long one, loops around the midbrain and averages around 50 mm in length. And there are direct perforators and peduncular perforators, as we saw in the P1 segment. And then there are these choroidal arteries which come predominantly from P2, and posteromedial choroidal artery is one of the predominant branch of the P2 segment, which has two segments. So we can see here this posteromedial choroidal artery. It has an undulating course as it passes through over the quadrigeminal plate, and it gives an undulating three kind of pattern, which can be seen here. That is how you identify the vessel. Then there are temporal arteries. There are 3 temporal arteries, all anterior, middle, and posterior inferior temporal arteries, and all these anastomose with the anterior inferior anastomose with the anterotemporal branch of the MCA. And the prominent among the 3 is the posterior inferior temporal artery, which travels towards the occipital pole and supplies the inferior temporal and occipital surface. And to identify it, there is this PCA pitchfork. Like this is the appearance of the posterior temporal artery. So among this, the cluttered, when you see a cluttered angiogram, the PCA, it will show a pitchfork along with that. This is the posterior temporal artery. Then coming to the parieto-occipital arteries, and these are the calcaneal arteries. And coming to the P3 segment, it is the smallest segment, straight segment, and from each side, after P2 loops around the midbrain, from each side it comes nearer to each other. And these two PCAs, when they come nearer, that is also called as a collicular or a quadrigeminal point. And sometimes it gives origin to the parieto-occipital artery or posterolateral choroidal artery. Most of the times it doesn't have any branch. So this is the collicular segment. As after the P2, we can see that these two segments have come nearer to each other, and this is the P3 segment. Then coming to the P4 segment. P4 segment predominantly gives origin to the calcarine artery and travels posteriorly and medially within the calcarine fissure to reach the occipital pole, primarily supplying the visual cortex. So here we can see the P4 branches. Also, these are the calcarine branches, and these are the parieto-occipital artery branches. So here we can see the P1, P2, P3, and P4. So after this, we'll just briefly talk about some of the pathologies. We had seen the fenestrations in last discussion. So here we can see the basilar artery fenestration. Predominantly, it is seen at the fusion of the vertebral arteries. But here we can see there are two double fenestrations. One is seen over here in the mid-basilar region. Then coming to, sometimes there is no fusion of basilar artery and it remains completely independent of each other. So here we can see the double lumen of the basilar artery and the non-fusion of the basilar artery. Then coming to the aneurysms, as we know, aneurysms are very common in basilar, the junctional regions, the basilar and the bifurcation where the PCA is formed. So here we can see the tip of the basilar aneurysm, and here we can see the P1 segment aneurysm. Also, perforator aneurysms are also seen. As we can see here, there is a mid-basilar perforator aneurysm at the origin of the aneurysm of the perforator. Here we can see the PCA perforator aneurysm. And in this picture, we can see this is the SCA and this is a SCA aneurysm. And this will be the last slide where I just wanted to show the top of the basilar occlusion. And this is the basilar artery dolichoectasia. Thank you.
Very nice presentation, Radhika.